Welcome, everybody. I am Nicolas Kozakowski from the Medical University of Vienna, and I have the privilege to co-moderate this ClomCom webinar together with Muthukumar Thangamani from the Weill Cornell Medicine in New York. The title of today's webinar is Spectrum of Transplant Rejection, Implementing a Scalable Framework of Activity and Chronicity.
Nico, good morning, good afternoon, and good evening to everyone. It's my distinct honor to be here to moderate this session along with Nico. As it was pointed out, we have 4 distinguished speakers today. The first topic for today is the description of the complexity of existing BANF classification and the subcategories of rejection, the clinical and pathological aspects by Professor Parmjeet Randhawa.
Muthu and Nicholas for this opportunity to talk and for introducing me. Greetings to my GlomCon family members, listening to whom has become as important a part of my life as paying attention to the Sunday sermon from our community priest. These are my disclosures. None of them are relevant. So the first point I want to make is there is now a panoply of rejection-related diagnosis categories in the BANF system for allograft pathology. We have category 2, in which we do know what active ABMR is, what chronic active is, what chronic is, but now we have incomplete phenotypes, some of which are listed here: C4D staining without rejection, acute tubular necrosis, and that new kid on the block, C4D negative, DSA negative microvascular inflammation. Category 3 has the conventional borderline and also borderline biopsies which fulfill ABMR criteria. Category 4 has acute and chronic active TCMR, and then there are mixed categories. There is acute and chronic TCMR, acute chronic active and chronic ABMR. And if you take these 2 terms, you can actually have 6 different combinations of mixed pathology. So it's really becoming difficult to keep track of. The second point I want to make is that transplant pathology diagnoses, as you all know, are based on scores assigned to histologic lesions. So the BANF 2019 schema has listed these regions. There are acute BANF scores, GIT, VPTC, C4D, chronic BANF scores, CGCI, CTC, VPTC, ML, and then we have acute and chronic scores, total inflammation, I-IFTA, T-IFTA, and polyoma virus load. So when we have the BANF lesion scores, why do we need activity and chronicity scores? I think the most important reason is that biopsies with the same diagnosis can differ in extent and severity of pathology. For example, acute and active TCMR can have scores varying from I2T2 to I3T3, which means that the inflammation in the biopsy can vary from 26% to 100%, as you can see in that picture here. Similarly, active ABMR scores can vary from G1 PTC0 V0 to G3 PTC V3. There are therefore potential benefits of summing up those acute scores in what we might call an activity index, and the potential benefits are measuring total inflammatory burden over a wider dynamic range instead of just 0, 1, 2, 3, helping decide the urgency, intensity, and duration of anti-inflammatory therapy, monitoring treatment response in follow-up biopsies when indicated, and prognosticating the transition of acute allograft injury to chronic kidney disease. Similarly, I can list some benefits of summarizing chronic scores into a chronic chronicity index. It will measure the irreversible component of graft injury, assist in recruitment for clinical trials, for example, focusing on chronic active ABMR or chronic active TCMR. You could use it to identify patients in whom further changes in immunosuppression are futile, for example, if the advanced chronicity is seen, and we can use these scores to develop prognostic models to predict time to graft loss. So to give you an example of what we can do in this field, I will quote this study from Mark Haas, who has devised activity and chronicity indices for ABMR. So the activity is measured by the glomerulitis score, peritubular capillitis score, arteritis score, and the C4D frozen section score, all graded from 0 to 3, so that the activity index can have a score ranging from 0 to 12. And similarly, the chronicity index is measured by CI, CT, CB, ranging from 0 to 3. And chronic transplant glomerulopathy, the CG, is given a weight of 2. So it can vary from 0 to 6. And therefore, the chronicity index can vary from 0 to 15. So this score by Dr. Haas is only validated for ABMR. So the activity and chronicity group of BANF, which is speaking today, has proposed a global activity index, which will be applicable to ABMR and PCMR and mixed. And why do we need such a score? Well, the BANF lesions are not mechanistically specific, and also mixed phenotypes are encountered. So we need a system which can handle all these kinds of rejections in different combinations. And what is being proposed, and it's published recently in Transplantation, it's actually still in press, I think. They suggest that the G, I, T, PTC, and D each be scored from 0 to 3, which will add up to 15. And the C4D should be scored as 0 if negative, 2 if positive. Whether you're using definition of frozen or formalin fixed doesn't matter. So therefore, that score will have a range from 0 to 70. I would like to suggest that there are some ideas we should explore which before we finalize the scoring system. In fact, I think we should measure the total inflammatory score instead of just the non-fibrotic score to fully capture the inflammation in late biopsies. And similarly, I think we should score tubulitis anywhere, whether it's in non-fibrotic or fibrotic areas is not that important in my opinion, because one transitions to another. And neither of these two scores can capture the total burden of intratubular inflammation. In fact, I would make a case for measuring total inflammation as being very strong. Its importance has been shown by classical studies from Edmonton. It has been confirmed by prospective and cross-sectional decaf studies in kidney transplantation. Even in the native kidney, the Boston biopsy cohort showed that the inflammation in the non-fibrotic areas itself is not predictive of chronic kidney disease. If we look at SLE activity index, C3 glomerulopathy scoring system, they all